So greetings, everybody. I want to acknowledge that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, the Tsleil-Waututh nations, as well as the Métis chartered community of the Lower Mainland region. And most appropriately today, which is Earth Day, and happy Earth Day to everybody. I hope that you all are learning more about the land that we're on and treating it with respect and the respect that it deserves so that we can stay living on it. And I think this is very appropriate for today. So with that, next slide, I want to introduce Dr. Carolyn Stigant. Many of you will know her, but not all. So for context, she's a nephrologist at the Island Health with combined interests in clinical nephrology, planetary health, medical education, and quality. She conceived and delivers the UBC undergrad medical lecture, The Climate Crisis, Planetary Health and Medical Practice, a Call to Action. And she's a co-recipient of a grant to reduce environmental impact of medical care in Victoria area hospitals. And she's the inaugural chair of the Canadian Society of Nephrology's Sustainable Nephrology Action Planning, the SNAP Committee. And really, I'm thrilled that we found this day so appropriately for this talk. So Carolyn, over to you. Thanks.
Thank you. I hope everyone can hear me. I'm coming through now.
Yeah, perfect.
Before hopefully I can figure out how to share my slides, but before I transition to that, I have a show and tell object. It's probably been a while since any of you have partaken in show and tell, but I want to just put this object up here. We're going to come to its significance in the coming slides, but I think you'll agree it's an interesting piece of earth, and it's kind of otherworldly looking, sort of unlike a rock that we may see regularly. So, get my slides up. And hopefully those are now visible to all. Okay, so yeah, a happy Earth Day. And I'll acknowledge that there's some stuff in this presentation that is personally challenging to me and likely will be personally challenging to people on the line. But I'm really trying to gear this towards accessibility, daily changes that we can make in our personal lives and in our work lives, and want to have a celebratory tone for this beautiful planet that we live on. These are my disclosures. And I wanted to start with my own acknowledgement too, because I think it's so important to root ourselves in Earth's natural systems. So I live in Wasanich territory, and a lot of the intellectual activity is for this talk was conceived there. And I'm delivering this from Songhees and Esquimalt territories. And the Saanich or Wasanich website has been a source of inspiration and information for me. And these images were taken from there. So in terms of lunar cycles, we're used to a sort of a 12-month calendar, but there's 13 lunar cycles in the Wasanich calendar. And we're currently in one called Exanal. I have it on authority from one of my Sartlet patients that's an adequate pronunciation. And this is the bullhead moon. So in their world, this is when these bullhead fish return. They're apparently a great delicacy, and because they are close to the shore, traditionally they were harvested by women. The swallows depicted in the stars here return at this time, and grouse were plentiful in the land. So those were the foods that were eaten. And in terms of astrology, the three stars that you see here that make up what we know as Orion's belt are called duck hunters, and they're low on the horizon. So these are our objectives for today, and these were posted, so you should be familiar with those. And I wanted to start with a bit of perspective. That rock that I showed you is a very old rock. My aunt is an amateur fossil hunter, and she was up in Norman Wells. And that part of Canada was once an ancient seabed. So that rock with its little undulations and bubbles was probably some gas bubbling through an ancient seabed. And it was around this time here of the Devonian period, about 400 million years old. And you can see here the Earth's history goes back beyond 4 billion years old. And complex mammals, of which we're one, are newcomers, as we all know. So by some accounts, hundreds of thousands of years, and our earliest predecessors, perhaps into the millions of years. But we're in this Holocene epoch now, which is the era, the 11,000 or so years since the last ice age receded. And this is the tough part here. These axes mark cycles of extinction, mass extinctions. So we're all kind of familiar with the end of the dinosaur era, but that rock came from this late Devonian extinction when about 75% of life on Earth was wiped out. And I think what's compelling to me in reading about these extinction events is we tend to think of it like the dinosaur one, like one huge event. But in actual fact, there's a lot of theories about what caused extinctions, and aberrations in the chemistry of the planet are huge and striking. So in that late Devonian period, the story was very different than our current story. It was a story, despite the picture of all the rocks that you see here, of plant success. And in fact, large plant species were felt to be so successful that they deprived the air of carbon dioxide. And there was, if you will, a reverse greenhouse gas effect. Things got too cold. And the fossil records indeed show that everything got very cold and it wasn't hospitable to life. And we're in kind of a different situation now. So I've showed this graph before. This is our current level of atmospheric CO2. Since this graphic was made, it's edged closer to 420 parts per million carbon dioxide in the atmosphere, unprecedented, going back to 800,000 year history. This principle of greenhouse gas retained within the atmosphere, returning some of the solar energy and thereby warming the planet. So the Intergovernmental Panel on Climate Change, or IPCC, sixth report has been recently issued, and they don't mince their words. It's unequivocal. This is human influence that's formed the atmosphere. And you can see here a simulated effect if there was only sort of natural, like volcanic activity. But here we have the observed versus their modeled. And you can see there's this exact overlap of the lines. These models are through multiple iterations are very good. And the average temperature is up by around a degree. And, you know, that's imperceptible to us, right? So what does it mean for average temperature? As I've said before, it doesn't mean a whole lot. We're in the north, and we know that the poles warm more than equatorial regions. And for those of you who follow news or weather news, you might have in fact heard that there was a recent heat wave, and that was in Antarctica. And temperatures were 50 degrees warmer than their average. So the poles are warming faster. Canada, being a northern country, is warming faster. We're seeing greater changes. And some reflection here that average global temperature difference was only 5 degrees Celsius between the last ice age and current. So if we're already 1 degree there, we're talking major, major ecosystem change. There's a lot of numbers on this slide, and I want to just walk people through this sort of numeric scenario here are modeled emission pathways. So the current sort of business as usual is this middle approach. So these are if emissions of greenhouse gases continue. The most optimistic, if we can majorly transition off of carbon, is this pathway here, and the worst if we accelerate is this pathway here. And I think what's really key, I hear in talking to a lot of people, they say, oh, well, when things go back to normal, or when we sort this out, is that normal is temperature rise, and normal is climate change. So I think everybody needs to understand that the best estimate in the near term for a temperature rise, no matter what we do, is 1.5. And by mid-century, the best estimate is 1.6. So we're seeing a lot of changes at 1.1. It's going to warm further as a certainty to 1.5. And how much further it warms beyond that is in our hands. So it's time to act. This is also a bit sobering that, you know, we hear a lot about the COP meeting. We're hoping that everyone's made good progress. And the Paris Agreement tells us that to keep global warming below 1.5, that emissions have to reduce by 45% below the 2010 level by 2030. And that's why this talk is titled Towards 2030. This is coming fast. Now I've put in red here, I think, a stark reflection of where we're at, that even with these pledges, we're way higher than we should be. And so COP has helped, yes, but we're failing by less than we were failing before, and we're still failing impressively. So big, big changes are needed. I don't want to dwell on this too much, but this just demonstrates for every, on these different emission pathways, for every degree of temperature change, that global effects will increase. This also came from IPCC 6. Again, a bit sobering reading, but they have dozens of these kinds of impact projections. So you can see here different degrees of risk, different degrees of certainty of these predictions. And I've chosen sort of the major ecologic worldwide projections here. Unique and threatened systems, which in Canada include glaciers and the way of life for the Inuit peoples. Extreme weather events, which sadly we've experienced here in BC. Distribution of impact speaks to unequal distribution, that some people are more vulnerable to climate change than others. People that live in coastal areas, low-lying areas, people that work outdoors, people that are in societies without defined robust healthcare systems, etc. Global aggregate impacts refers to global ecosystem degradation and the cost of these disasters that happen, and large-scale singular events could be things such as ocean current slowing, which affect weather patterns. So here in BC, we're familiar with this, sadly, and these are our colleagues in Williams Lake when it had to be evacuated from a forest fire. So big impact on our kidney care provision systems. This is a graphic from Canadian Medical Association showing the variety of climate change associated health challenges. And I won't elaborate on these, but good, helpful graphic here. And these are not mutually exclusive, of course, by area. So we may see more insect as vectors and pathogens change, more allergy illness, COPD exacerbations, pulmonary infections, topographic changes, food security changes, particularly in the north, migrating people, and tremendous social stress from these issues. So I showed this one last year as well. 1 in 4 deaths are linked to the environment. This is a shocking number for us here, where we code and tend to think of our disease processes as independent to environmental processes. At least I did. And this graphic to me was completely surprising, that the causes of death from the environment, top 1 and 2, would be stroke and ischemic heart disease. And it makes one wonder, with kidneys as vascular organs, how kidney disease might be affected as well. The fossil fuel component of air pollution is responsible for a good chunk of these and causing premature death. So particle pollution, or so-called PM 2.5s, there isn't one chemical that makes this up. This is a variety of sulfur oxides, nitrogen oxides, hydrocarbons that vary by industrial activity and combustion activities very, very locally. But this was taken from a review article in Circulation in 2004. And this pathophysiology really spoke to me in terms of understanding why vascular disease is accelerated by air quality. So here we have these tiny particles going right into the lungs, right through the alveoli, essentially diffusing in our body, transporting throughout our body, contributing to atherosclerosis, plaque instability and rupture, activating the autonomic nervous system. So suddenly we have this clear pathophysiology of how we are affected. This was an analysis that demonstrates a very significant reportedly association of kidney disease with atmospheric 2.5. So these investigators looked at concentrations of air quality, these PM 2.5s around the world, and they compared to various databases of prevalent kidney disease, and they used known dose response data in terms of smokers and environmental short-term exposures to extrapolate the burden of disease. And it makes me wonder, you know, looking at these shocking numbers, potentially attributable CKD in Canada in the 60 to 100,000 odd range. These authors also included disability adjusted life years, because of course we wouldn't die from this or feel morbidity from this instantly, but the estimate was 3 to 9 disability adjusted life years in Canada for CKD component from air pollution. So here, climate change and kidney disease are really intricately linked. And I think this is clear to us: rising temperature and heat stress, volume depletion, repeated episodes of subclinical volume depletion, contributing to acute kidney injury, certainly to chronic kidney disease, stone disease, and then through these various other climactic or environmental issues affecting our care delivery systems and potentiating other disease processes. So shifting to healthcare then, as we transition to kidney care delivery systems impact, healthcare is a major industry worldwide, and as such, we have a major ecologic effect, just under 5% in fact, and this is equivalent to airplane travel. Canada's statistics are fairly close there, so good for us to keep in mind. This is a bit wordy, but I think the point here is that all our healthcare leaders, all our governing bodies, all our healthcare funders are telling us that we need to incorporate sustainability into medical care. As health professionals, we must do all we can to aid the transition, and that will mean changing how we do things. Ministry of Health, Health Canada has signed on to the COP26 health program, developing low carbon sustainable health systems, and our own BC Renal with an objective for a sustainable renal community. So Catherine Barraclough, who was the first speaker in the series that we've been doing here on climate and kidney, I think very eloquently said that we can't see this as an optional extra once this more pressing concern of patient care has been dealt with. So I know a bunch of you on this session feel like I do, and that as worthy and good and needy and valuable as our dialysis care provision is, that it's hard to see this. It's hard to see the buckets and the reams leaving the renal unit here. I didn't picture PD, but the patients at home are impacted by what they're putting into their bins. And on the right side is a graphic a patient of mine took. She lives in Saanich. She's on next stage home hemo. They don't put any of their house garbage in here. This is all her dialysis associated garbage. And this is 1 week's worth. So in Saanich, the garbage is collected every 2 weeks. And the second week, she told me she had to take to her brother's place. He lives in a condominium, and she couldn't afford to pay for the extra bag. And so this was a patient asking me, is there anything we can do about this amount of waste? So the NHS is the national health system in the UK. And the UK government has really mandated that these Paris targets for carbon reductions take place across society. And so they have this nationalized health system that's enabled them to do this. And so they started in the logical place with data. And I think they've done the whole medical community a tremendous service with this. Hopefully this is not a new graphic to many of you. But I think you'll see of this pie chart here in terms of the emissions, about 2/3 come from activities that are directly really upstream from patient care. And I don't think this necessarily gets us off the hook, but I think it behooves us to be mindful of what we're prescribing, because the small medicines that we use, the syringes that we use, the dialysis circuits, the PD bags, they all add up, right? And they're incorporated in this footprint. So how to prescribe this stuff meaningfully. Building energy is another one. Our patients come to our buildings. We come to the buildings. So travel is a big component of the footprint, as is water and waste. So we'll keep this framework in mind as we move forward into considering kidney systems. So the only comprehensive look at carbon footprint of a renal service that's been published, the entire service that is, came from the UK again, and this was in 2010. And this community was a fairly similar size and catchment area to Victoria. They had just under 1 million people. And you can see here quite a startlingly similar kind of footprint, that building energy use, travel to the unit, and then this procurement, large procurement category with waste, medical equipment, and pharmaceuticals being their main contributors. So this is what informs us as we go forward. some investigators from Utrecht have done a similar kind of analysis, and they came up with this statistic that the per treatment carbon emissions from hemodialysis is 30 kilograms, which is roughly equivalent to driving 100 kilometers. So if you think about that in terms of carbon cost, and that's a useful sort of frame of mind number. The literature, however, is really wide range of what the impact is. And I'm sorry to PD people that this is hemo heavy, because that's where the bulk of our data is. The one study that tried to comprehensively look at PD emissions did not have data from companies. So they couldn't include manufacturing, they couldn't include shipping. And we know how heavy those things are in shipping, and that's got to be a major part of the footprint. So I don't think the PD data would be really meaningful. And similarly, we don't have transplant data yet. But, you know, we're talking major impact here. It's 4.7 tons is the average US gas car emissions. That's from the EPA. So it's kind of like driving a gas car around an average car for an average distance traveled over a year. And it's roughly equal to, this is the Canadian average per capita CO2 emissions. And this is just national level, national data here in Canada. So it's about, you know, roughly half. So it's adding 50% per dialysis patient, if you will, to their footprint and their impact. So the NHS has, as I said, got a system here and a pledge, and they've got a pathway to get to net zero. And it's through chipping away at all of these different aspects. So I think this is a really useful graphic and one to get some informed practice from. I want to just, or I know this is blurry. I'm not sure how well you can read it, but this is just, to me, a very conceptually helpful picture. And in some of the slides we're gonna look at, they refer to carbon emissions. This is not a carbon emission graph. This is on the y-axis here is climate resilient development. So this is the one time we want to see this going up. So if we can steward the environment, if we can be effective in knowledge delivery, if we can work on our technologies, we can have these synergies that will improve climate resilience, leading to better outcomes. And this is all through Sustainable Development Goals from the UN. Compare and contrast to increasing warming, where we have dependence on and limits on adaptation that could undermine sustainable development. So just think about those synergies as we move forward. So Healthcare Without Harm has published a global roadmap for healthcare decarbonization. And very helpfully, they've given a lot of regional strategies for how we can go about doing that. So by now, these different categories will sound kind of familiar to you, because we've talked about these in the previous slides. But you'll see in Canada, investing in zero emissions building and infrastructure is a really big part of lowering our healthcare footprint, powering our facilities with clean and renewable energy, improving efficiencies and effectiveness of our system, and so forth. So a lot of you are, I'm sure, thinking this has nothing to do with me and my individual practice. And to some extent, you're right. I think that there's room for us to voice up and to say that we want these things done. Our government needs to listen, that this needs to be priorities. It's impressive in the US, at least, they've got a plan for decarbonizing their healthcare sector, and they're looking at similar things, reporting greenhouse gas emissions, including greenhouse gas emissions as a measure of health system effectiveness and safety, learning, incentivizing, educational initiatives, different funding, updating regulations, changing standards of care. So we need a lot of help through not only government, but also through industry and through the public. Lots of room for innovation in healthcare climate action, and there's no shortage of examples here, and would encourage everybody to think about this. So these might be sort of lean care pathways. One example that's been talked about in the nephrology community might be a same-day investigations for kidney transplant donors, where they're not repeatedly coming to a healthcare facility. All of these appointments may disincentivize donation, for example. So think about clinical care pathways that we could streamline and improve, as well as processes that we could improve on. So here's where we are in nephrology. We have no idea where our emissions are. We don't really know how far we can go. You know, I'm not necessarily proposing that we need be or could get to net zero. I think that remains to be seen, how good we can get, but clearly I think we need some objectives, and my feeling is that we need to be held to account just like everybody, so that we can dig our teeth in and really make some progress in this area. So as we're talking subsequently, I want people to kind of think about this macro, meso, micro levels of involvement. This has been, although it may seem abstract and unrelated, it helps me conceptually. So micro are your individual levels. Meso are the levels of the system in which you work, maybe your dialysis program, your home program, your kidney clinic program. Maybe we could lump BC Renal in there. And macro is the system at large. And I've really learned that the micro informs the macro and vice versa. And here's a little example of that. So one of my hospitalist colleagues and I have this sci-fi grant, and we're trying to change some sort of seemingly simple things around the hospital. Like we should be getting rid of all these single-use plastic. We shouldn't be seeing patients use these, you know, urinals, for example, or this Vernicare single-use disposable stuff. We should be using reusable gowns. We should be minimizing glove use and using it only when appropriate. And so we quickly realized that we needed to have a lot of conversations with a lot of people, because there's systems behind this. Purchasing chooses these products. You know, there's a lack of a dishwasher to deal with reusable products. There aren't proper signage systems for ensuring that the gown that you're grabbing is not coming from the dirty bin. So lots of different potential barriers that have to be overcome that involve a lot of people and a lot of systems. So recognizing the need for cooperation, discussion, and widespread change. I'm very grateful to the Canadian Society of Nephrology for allowing us to form this Sustainable Nephrology Committee. And we had our first meeting on January the 6th. And the first meeting was really an introduction and setting our vision and our mission. We really started with, I think, a strong foundational structure. And I'm particularly fond of our verb-laden mission statement, because we really want to get things done. The next was moving on to foundational values. And this is, in a sense, sort of motherhood, but I think it frames these activities in a really appropriate way, with this wider scope for respect for social and structural determinants of health and traditional knowledge systems. So planetary health, as I said it at the last meeting, really speaks to human disease that's caused from disruptions of Earth's natural systems. And that's what we were talking about on the earlier slides. I am very proud that the CSN is the first nephrology organization worldwide to have signed on to this declaration. And at the individual level, guided by principles of this planetary health pledge of the Anthropocene. This is, in essence, an updated Hippocratic oath that speaks on an individual level to the concepts within this declaration. So this is incorporating these concepts and values, educating patients, using our trusted voice, drawing on diverse knowledge. And every person in every place has a role to play. So these are current SNAP members from across the country. Really happy to encompass most of the big renal programs across the country. We have pediatrics representation with Kristen and Keith as well, and a nice strong contingency here from our West Coast. And we're really working on building this network. BC Renal has been a very helpful conceptual model for me in taking this forward, because I really like it how Dr. Levin tells us usefully that we are BC Renal, and collectively we make up this community. And I'd like to think that everyone has a voice in this. We certainly welcome viewpoints. The idea is to have this communication network where everyone can have an idea, and we can work to implement these kind of ideas, and we can share our ideas across the country. So network building is really important. For those of you who were on my presentation last year, you might remember that we weren't doing towards low carbon kidney care yet. We were doing towards a planetary health framework in nephrology, which was really laying the ground roots for that. So we walked through this system. So what we were talking about working on conceptually last year, we've just submitted as our first SNAP investigators proposed publication, waiting to hear back from the journal about this redesigning kidney care for the Anthropocene. And we really want to focus on these upstream health promotion, disease prevention, chronic disease management, because the more we can keep people away from end-stage disease, the better for all. In terms of matching supply to demand, we're talking about conservative care when appropriate. We're talking about optimizing transplant, and home dialysis would be sort of the big ones. And then we'll talk about some of these reduced emissions in the coming part of the presentation. So this is also conceptually useful, this hierarchy of sustainability, if you will. It's sort of a reverse hierarchy, I suppose, in this diagram, but thinking about how to be more effective with health promotion. I think the money is in that, health promotion and prevention. I suspect my next talk will be more focused on that. Those activities are gearing up. I don't pretend to be a person who has all the ideas or is compiling all the ideas. This is a system change, lots of people working on that, lots of ideas needed. You might recall the transportation footprint in the nephrology analysis was 15% of emissions came from transportation. So a group of us, including Shannon Wong, the fellow, and some of us here on the island, are looking at carbon footprinting patient travel to hemodialysis. So we want to get a health authority snapshot of the carbon cost of patient transport, and we're planning to use this to appeal for policy and funding to electrify public transport to dialysis appointments. And of course, we're all mindful that these patients do not have the option of virtual care, apart from, of course, the home dialysis option, which we're trying to promote as well. Procurement is a major issue, and I think that SNAP activities would like to see more scoring of environmental indices within our contracts. But we also recognize that we have to know what vendors have to offer. And we also want to communicate to vendors that this is high on our agenda. And we are requesting products that are suitable in this new era. So we're putting together a green industry exhibit, if you will, and all CSN corporate partners are going to be issued a questionnaire with this set of queries, and 5 of the prominent large vendors, 2 dialysis providers, 2 pharmaceutical companies, 1 water service will be invited for a video conference presentation. And in particular, we want them to speak on what things we could use with our existing infrastructure, what we could adapt to improve the environmental sustainability or profile, what we could use with the next machine cycle, and what their vision is for system transformation. And an example that I've spoken about before might be a sorbent-based dialysis system. That will also be the subject of a future talk. We want them to comment on their environmental management system, their climate change plan, their manufacturing and shipping, waste management practices, including with us, the users and our patients, of course, the users of these products. And we're going to request, like the UK has, that emissions data be imprinted on the products so we can be informed about what we choose. So there will be a de-identified report that comes from that. So I've harped on about the need for emissions, and you may not be familiar with the term LCA, or life cycle assessment, but before we were talking about carbon emissions, and a life cycle assessment speaks to greater environmental, not just carbon emissions, but the greater environmental impact of the entire life cycle of a product. So you can appreciate that even, you know, a syringe or a pharmaceutical, you've got to mine some raw products, you've got to transport those to a factory, they've got to be made into a precursor ingredient, they've got to be made into a final product, transported to where they're used, and then there's sort of an end of life repurposing or the effects of it in the trash. So the entire cycle of life of a product. So there's a group of us here in BC. Taz Tasleen Rajan is doing her master's thesis on this, and we're very, very proud to be partnering with the Planetary Healthcare Lab at UBC under Dr. McNeil's guidance, and with our transplant surgery colleague, Dr. Chris Nguyen, for that important transplant group, with our colleagues in Island Health and in Interior Health, Drs. Michaud and Conley, and grateful to the support of BC Renal for some funding support for a project looking at LCAs across the spectrum of kidney care. So I think this is going to be really foundational work of broad interest to the nephrology community internationally, and it will enable us to compare apples to apples about our different therapies, but of course also to determine the effect of different interventions. So one example might be, let's say we can campaign for coverage of SGLT2 inhibitors in people who are appropriate to receive this medication. One of the ways that we could then appeal for that medication to be covered is to say, look, we can spare this many years with advanced kidney disease or end-stage kidney disease, and even with transplant, and that could be an additional argument, cost and environment-wise, over and above the clear patient care advantage to these more desirable therapies. So next steps for SNAP then are to work on this network building. This talk is hopefully going to be given in multiple settings across the country by different SNAP measures. We'll be going forward with some of the initiatives that I've discussed. Patient will be involved, and I want to focus now in the last remaining slides on how to implement sustainability in kidney care programs. So I've got sort of a 10-step approach here. So the first thing I think is, and I hope I've been persuasive in this, is to accept change. And I want to be clear that I think novel approaches have to be on the table. Optimal patient care is still and always will be the goal. We're not talking about scrimping. We're not talking about denying services to patients, but how to incorporate economic and environmental care and provide our care smarter. So I think to do this, we have to get ourselves aligned first. So live, enjoy, and I really want to stress this enjoy, because I think that a low carbon lifestyle does not have to be a story of deprivation. In fact, quite the opposite. And I found that as I've embraced these changes in my life, I find that it's extremely gratifying to live in a more sustainable way. It feels right, it makes sense. And this is one example of this is actually very widely studied and proposed. C40 cities are a group of major cities across the world which are dedicated to carbon neutrality, and they join forces with investigators at the University of Leeds and a major consulting company to come up with this very approachable kind of recommendation. So this really speaks to the fact that people say, oh, what difference does it make? What difference does it make what I do? But actually, I think it's very, very important what you do. Your actions can influence other people. Your actions can make this a norm and can change the kind of dialogue of what we appreciate in society. Maybe the fastest car isn't the standard that we should be aspiring to, for example. And also the add up effect. If someone sees you living a nice, sustainable lifestyle, they'll realize that they can do that too. So making these 6 commitments could account for 1/4 of the emissions reductions to limit temperature risk to 1.5. So I think incorporating this into our patient messaging and our patient care is really, really important. The third is that I'll strongly advocate that we need a sustainability program. If we're going to get results, we need to hold ourselves accountable here. I think we need funded positions, and I think this is something that will pay itself off in spades. We can define our priorities, set deliverables, collect data. I don't have time to get into it today, but I'd like everybody to look up these resources here. These are step-by-step approaches to priority setting and to implementing sustainable measures within the healthcare setting. some of you saw me walking around taking pictures in the renal unit, and it was for this little collage of what we could do in non-patient care part of our units. So work to reduce printing, get the power saving, double siding, think about what you're printing. You don't need to print. Think about climate control. Now we have to be, there's a CSA standard for temperature, but perhaps in our clinic settings or our office settings, we could think about the thermostat, appropriate sorting of waste, turning off the computer or low power settings, dimming the lights at night, those kinds of things, lower energy bulbs. And then I think for bigger impact in the clinical care areas. So injectables, Dan and I, Dr. Dan Martin-Newson and I were talking yesterday about how to get more bang out of oral medications and rely less. Look at all these supplies. You all know this, that are associated with IV medication. Again, when appropriate. Ordering and inventory control. Our local Duncan unit has a great program and has reduced the amount of supplies that they're ordering and reduced the number of expired products that they're throwing away. So that's a big opportunity. Proper labeling of clean and reusable materials, preferring reusable when we can. The proper uptake of virtual health. And then second thought as well about when lab testing is done. Is this a need to know lab test? Is this a I'd like to know lab test? And kind of thinking about the suitability. And I think that's an area in need of data. So establishing and tracking key performance indicators. France has done this in their Fresenius unit since 2005, and they issue monthly sustainability reports. Now, I think we have to be careful with what KPIs we choose, and I appreciate fully that there is a perhaps incentive here. I don't want to say that we need to scrimp on a patient dialysis prescription to achieve these. Again, this is working on operational efficiencies. They upgraded their facilities, they upgraded their climate control system, they upgraded their water, they captured RO reject water, and they're using it for gray water purposes. They reduced their care-related waste production, and you can see these are per treatment reductions in kilowatt hours, liters of water, and weight of their single-use disposables. And they reduced these carbon emissions. Now, again, this is per treatment, but they've grown hugely, and so overall their emissions have increased. And that underscores the importance of not growing these end-stage programs and underscoring again on prevention. Medication stewardship. I think we're quite good at that here with MedRec. MedRec and deprescribing kind of go hand in hand. I've talked a little bit about reducing IV medication use, and I'd like to see a widespread implementation of proper medication disposal. That doesn't have much to do with reducing carbon, but it does have other implications for health of our ecosystems and how we dispose of our medications. You'll note that this list here for green dialysis prescribing is not going to add up to a whole lot of carbon savings. We don't have a lot of evidence yet, and we're going to be exploring again with manufacturers for what we can do. But again, when appropriate, not to scrimp on a prescription, but is there room to reduce the dialysate flow, to prescribe incremental or decremental? An online prime would decrease the use of the PVC plastic saline bags. There is evidence that Next Stage has 50% lower carbon footprint than the other forms of home hemodialysis. So if there's equipoise in choice, we could, for environmental reasons, suggest or consider Next Stage. Acid concentrate options, instead of this big jug, I think in the UK, they've got a smaller size jug with smaller volume and there's a dry powdered option as well. And then when appropriate, conservative management. So green dialysis prescribing for PD, kind of similar. This is not going to be a make or break state of the art where we're at right now. And again, consider when it's appropriate to implement these types of things, and room for lots of innovation in the plastic or single-use area. These are a variety of sustainability resources. I wanted everyone to have these and would encourage you to look here and be inspired to be a green champion as number 7. Number 8 is we can think bigger than our kidney sphere, again with optimized chronic disease prevention and general management strategies. We can be familiar with the Choosing Wisely initiatives. And then one big example, so 5% of that NHS impact came from the greenhouse gases that come from these carbon intensive metered dose inhalers. So this is like Ventolin or Atrovent. So they have accelerants in them that are fluorocarbons, and they're intensely more solar energy trapping than CO2 is. And so there's a movement to switch to dry powdered inhalers which don't have those greenhouse gases associated with them, and you can see the much lower carbon footprint. So if you look at the Cascades Canada website, so Cascades is our creating a low carbon health system in the climate crisis, cascadescanada.ca, they've got a very user-friendly chart of how to convert, and hopefully hospital formularies regionally will have some updated prescribing advice on that as well. Low carbon transportation I've touched on. And the last thing would be to have a rock solid adaptation strategy given the challenges that we've seen and recognizing this very unique vulnerability of our patients in terms of their disease burden and their reliance on care provision pathways. In 2 weeks, we're having an inaugural phone call with a group of similarly minded people from around the world. We've got some Dutch representatives, UK representatives, Australian, myself. We're hoping for a wider spread. And the emerging objective is a manufacturer's challenge, where there's this really, I think, nice innovation challenge to help the manufacturers come up with better products. So to summarize, nobody wants kidney failure, most of all the patients. It's environmentally costly as well as being financially costly, and severe consequence, of course, to patients and healthcare systems. We've got effective treatments for kidney disease and preventive strategies, and end-stage disease is incredibly carbon intensive. In terms of future directions, we'll work on this LCA data. We've got to get key performance indicators up and agreed on, tracked. Better prevention, as I've said. I think it's worth defining what ideal low carbon kidney care looks like. This is sort of some introductory ideas, but to sort of solidify that and to work on building this network and recognize that we've got purchasing power in numbers. So I'll conclude with that, and hopefully we've got time for a good discussion and leaving you with some scenes of inspiration here across the seasons in my world. Thanks everyone for being here.
Thanks, Carolyn. You'll stop sharing your screen and then we can probably see people there. There are already some questions, you know, they're beautiful pictures. There's some questions. I'm going to read them. So how do we develop and push for a province-wide plastic recycling pickup service for people with kidney disease for the home dialysis? I think we've been talked about before, so that would be one question. And then our new build hemo units looking at recirculating or any other interesting ways to use gray water. And lastly, can we include planetary health in the fellowship program? And there's a lot of thank yous for really inspiring at talk, not just on Today Earth Day, but just in general. And it's really, really important for us to think all of our footsteps throughout the process of care. But those are the 3 questions that I can get you to start with, if that's okay.
You know, I'm very sorry, Adira. I hit leave instead of stop sharing. I hope I've stopped sharing.
Yes, you did.
And
you stopped sharing.
I'm going to, my apologies for leaving briefly then. Can you repeat the question?
Sure. So can we, or are you, or can we develop and push for a province-wide plastic recycling pickup for our home patients or for our services? That's number 1. Is there a way to influence our new build hemo units by looking at recirculating water or other uses for gray water? And then lastly, I think you've already started it, but can we include planetary health in the fellowship training program? I mean, for renal in specific, but I think in general. So those are three good ones to get your.
Thank you. Yeah. So we need a lot of help. So the plastic recycling pickup is an interesting one. And hopefully people remember the presentation that Nisha Rao gave at BC Kidney Days. We determined on that analysis that there are 25,000 kilograms of PVC potentially recyclable plastic per year coming from peritoneal dialysis. And there's a big opportunity there for plastic recycling. This is an interesting problem. I think we need a recycling infrastructure. So I've reached out, actually, all sorts of different conversations come out of this, but there is an emerging, it's actually a trial program here in BC now looking at medical PVC plastic recycling. It's in Vancouver. So it is small scale. They haven't gotten dialysis supplies yet. There's no reason why they couldn't. But I don't think they're up to scale, and I think it's a year-long trial that they're doing. And so we're hoping that the ability to recycle PVC plastic from medical source that's not biohazard will be up and running provincially, but it's going to be some time still. For the polypropylene plastic, of which yearly there is about 9,000 kilos, patients currently have to drop that off. Recycle BC does accept that material, but right now the onus is on the patient. What we're hoping is to have a similar system like they have in Australia and New Zealand, where when the vendor drops off PD supplies at home, that they can pick up the saved non-biohazard plastics and that they could dispose of them for our patients. And I think that's something that we need to entertain in subsequent contracts, or see if we could work it into this contract. There's an ability to do that right now. I was in touch with a plastic recycling, a PVC plastic recycling vendor in Ontario, and they said they want our supplies. They want them. They're ready to deal with them now. These people are actually looking for a steady stream of what they call quality product. And the issue was apparently the provincial government blocked interprovincial export of plastic because it had something to do with carbon accounting, and they didn't want that done. So there's a lot of different conversations to happen. So if others are interested in engaging in those conversations, I would welcome that. We would need to get pathways to get the material there. Presumably we could piggyback on existing infrastructures for non-dialysis PVC plastics, but this remains an area of opportunity. I am a bit of a spoiler alert here because this isn't published yet, but Nisha and I expanded our analysis to worldwide, and we used very conservative estimates of worldwide PD data. And we said if all of the PVC plastic from PD worldwide was recycled instead of landfilled, the environmental savings would equal approximately getting 1,500 cars off the road. That is worthy, but it is like it's small potatoes, truly. And so I think recycling is on our mind because it's what we can do at home. I still think it's the right thing to do. It involves a giant infrastructure, and compared to prevention, it is, as I say, really kind of small potatoes. So I don't want to say don't recycle, but let's figure out how we can focus on the big stuff, which is the prevention. So I hope that adequately answers number one. Number two, in terms of the gray water, I'm probably not the best person to talk to. Our tech leaders, I think, would have something to say about this. The UK is doing this in their new builds. France has incorporated this across the Fresenius ones. Australia, which of course is quite water scarce, is capturing their gray water. And all of these initiatives have demonstrated cost savings. So all I can say is there's equipment and big infrastructure that's required to be in place. It I think if we stay with our conventional models, that this is something that we have to look at. But again, I'm not an expert on the sorbent systems, but I keep going back to that because what I've read about sorbent is that instead of using 385 liters of water per treatment, we can use 6 liters of water per treatment. And given that water purification is an energy hog and water is increasingly costly, in addition to being in short supply in some regions, I think we need to look at reducing all of that as well. So providing dialysis differently for our end-stage patients, I think is necessary. And that's what I like about the system transformation idea. The third is the fellowship, and I would say to that, why limit it to fellows? Of course, I can, we can do a talk, and everybody who comes through, I'm happy to talk to them about sustainability initiatives. But I think this is addressed to everybody. This is for everybody, and so I love this idea of again this analogy to BC Renal and SNAP. Like, talk to us. Give us your ideas, and not just us. We don't have to be in charge of everything. Just do something. So I'm hearing a lot, oh, I would do this more, but this, we're busy. This bin is too far away. None of this should make anyone's day more difficult. This should make your day easier. And so if someone just has an idea, like, I can't get to that bin. Okay, well, let's look at the layout of the unit. Maybe we should have like one of these flow analyst kind of people come to a unit, look at where the bins are, look at what the bins are, look at how we can sort things differently and just incorporate it so easily into our processes. So let's all be involved, and I'm open to ideas for the fellowship. I teach the medical students. Yes, I think I'm crazy. Obviously a sucker for punishment, because yesterday I signed myself up for BCMA Council on Health Promotion because I just think that promotion is so important. I hope they like my application. But like kidney care teams, all of us, when we counsel our patients, recognizing we get our patients late, like we can talk to GPs, we can tell them about how to screen for kidney disease, we can teach them how prevention is. So this is all the stuff that we do that's kind of supercharged because of this big impact.
Yeah, and I think you're certainly passionate about it, but I think we all should be. We live in this province. We've experienced our heat dome from last summer and our floods and everything else. And I think we all, perhaps more than other people in Canada lately, have felt the impact of climate change and can really think about how we put all this together. And I think, yeah, engaging all of the nursing staff and students at all levels is going to be really important. And I think, as we go around our day today, I think we should look at very, very simple things. As you said, let's look where the bins are. Let's look how easy it is to put something in a recycle versus a garbage. Do you really need to wear gloves, or do you just need to wash your hands more? And those are with soap and water, not those silly alcohol things, which also are problematic in terms of waste, etc. So I think you've really given all of us a lot of thought. You had a lot of positive comments, and for those of you that don't know, Andrea McNeil is on the talk, and thank you, Andrea, for listening. Kidney's not her thing, but she made the effort to come to this talk, and that's fantastic.
She's quickly becoming an honorary nephrologist.
That's it.
And she doesn't know yet the fire she lit in me, but she gave a talk and she called out on dialysis and nephrology as an area for needing improvement. So on a collegial sparring level, to have a surgeon tell a nephrologist they need to do better, it really hit home. So thanks, Andrea, for lighting the fire.
Yeah. Anyway, yeah, so thanks again. We're at time, and it was a fantastic talk. It is a fantastic initiative, and one that is not in any way going to lack a lot of enthusiasm, effort, and energy from all of us. So thank you again, and happy Earth Day to all.
Happy Earth Day. Yeah. Bye-bye.